Surgery of Ear by Glasscock and Shampoo, Chapter 28, Tympanoplasty and Tympanic Membrane Repair. Tympanoplasty approaches. There are three tympanoplasty approaches: transcanal, post-auricular, and endoral. Factors to be considered regarding the type of approach to be used include the size of ear canal, the location and size of the perforation, and the surgeon's training and experience. Transcanal approach. Small posterior perforations can be repaired through transcanal approach, especially when the size of the ear canal is large. By doing so, the inconvenience of the mastoid dressing and the slightly higher morbidity of the postauricular incision, pain, hematoma, and infection are avoided. In this approach, the edges of the tympanic membrane perforation are denuded of squamous epithelium and tympanosclerotic areas are completely removed from the remnant of the tympanic membrane. The middle ear is explored by elevating a tympanomeatal flap similar to the one used in stapedectomy. Pathologic processes of the middle ear are removed and the oscular chain is inspected and repaired as necessary. Should polypoidal mucosa or adhesions be removed, film absorbable gelatin is placed over the promontory to prevent adhesion formulation formation. The middle ear is then packed with gel form, gelatin sponge, and the graft is placed medial to the tympanic membrane remnant or tympanic annulus and the manubrium of the malleus. Finally, the tympanomeatal flap is returned to its original position and the medial aspect of the ear canal is packed with pledgets of gel film impregnated with antibiotic ointment. The patient is instructed to instill ofloxacin drops twice a day and to return to the office in 4 weeks for cleaning of the ear canal. For persisting small perforations, such as those following tympanostomy tube extrusion and myringoplasty failure, transcanal fat grafting myringoplasty is the procedure of choice in the majority of patients, with the exception of children who require sedation. This procedure can be done under local anesthesia in the ambulatory surgery center. The transcanal fat graft myringoplasty procedure proceeds as follows. Local anesthetic is injected into the four quadrants of the ear canal and into the earlobe. Through a small incision in the rim of the earlobe, a small piece of adipose tissue is removed and kept in sterile saline solution. The incision is closed with several 5-0 monocrystal sutures using microscopic visualization and a cup forceps. The edges of the perforation are denuded of epithelium. A piece of the previously removed adipose tissue larger than the perforation is inserted through the perforation in a dumbbell fashion. Antibiotic soaked gel foam is placed over the graft. The patient is instructed to instill ofloxacin otic drops in the ear canal twice a day. Avoid blowing of the nose and to observe water precautions. The ear canal is cleaned at the office at 4 weeks following surgery. This technique achieves excellent results if used in appropriate case. Post-auricular approach. The post-auricular approach is preferred for large perforations necessitating total replacement of the tympanic membrane, especially when the ear canal is small, and for surgeons with limited experience working through the ear canal. For cases with a narrow ear canal, usually due to a bulging of the anterior bony wall, canaloplasty should be performed at the time of tympanoplasty. Poor visualization of the anterior sulcus may result in improper graft placement and failure of the procedure. Endoral approach. This approach is popular in Europe for chronic ear surgery and stapedectomy. It was first described by Kiesels in 1885 and was later popularized by Lampert. The first incision in this approach is made along the entire posterior half of the ear canal at the bony cartilaginous junction. A second ventricular incision is made in the incisura and connects the previous incision and the area between the tragus and the root of the helix.